The ulnar nerve is discussed together with the median nerve in the hand, as these two nerves provide 2/3 of motor innervation to the hand. In ulnar nerve entrapments, sensory deficits involve the ulnar 1.5 aspect as shown in the diagram here. The diagram on the left shows the sensory innervation of the ulnar nerve in the hand. Yellow and blue is on the volar aspect while the green is on the dorsum. The diagram on the right shows the motor and sensory branches of the ulnar nerve. In compression at the elbow region, there is involvement of the branches to the FCU, FDP and dorsum of the hand as shown by the purple arrows, palmar sensory as shown by the green arrows, and deep motor branch supplying the intrinsics as shown by the yellow arrow. In compression at the wrist, only the branches shown by the green and yellow arrows are affected. Cubital tunnel syndrome is due to compression of the ulnar nerve over the medial aspect of the elbow region. The diagram here shows the close relationship between the ulnar nerve and the distal humerus on the medial aspect. Ischemia or mechanical compression due to repeated elbow flexion is a common cause. When the elbow is flexed, it leads to reduction in area surrounding the nerve, in turn leading to increased pressure in the cubital tunnel region. The pressure is further increased if elbow flexion is combined with wrist extension and shoulder abduction. Fractures occurring around this region leads to direct injury of the nerve or iatrogenic injuries during surgery. If the nerve is unable to glide as normal during elbow flexion extension, this also leads to nerve injury. Paresthesias are described usually by the patient as a sensation of pins and needles or feeling of ants crawling around the region supplied by the nerve. This occurs over the yellow, blue and green regions shown in the diagram with or without numbness. Motor dysfunction leads to muscle atrophy, weakness of the hand and clumsiness. Clumsiness is when the patient complains of occasionally dropping objects held. Compression can occur over these areas: the arcade of Strathers, Osborne ligament, and FCU fascia or its two heads. Decompression surgery requires release of all the compressive sites. Clinical examination is the mainstay of diagnosis. Electrodiagnostic studies may be helpful but can be normal. Ultrasonography is useful to confirm doubtful cases or when double crush is suspected. We have a portable ultrasound machine in my clinic and I sometimes use this modality. The nerve is compared to the contralateral side if it is normal. However, this tool has a steep learning curve. Ultrasound and MRI can show external compressions to the nerve and can be useful for pre-operative planning. The ulnar claw shows hyperextension of the MCPJ and flexion of the PIPJ and DIPJ of the little and ring finger. In high lesions, like cubital tunnel syndrome, the clawing is less severe, shown on the right side of this photo compared to low lesions. This leads to the so-called Ulnar Paradox. It is assumed that high lesions will lead to more severe deformity, but this is not seen in ulnar nerve neuropathies. Atrophy of the ulnar innervated muscles in both the forearm and hand can be observed. Loss of sensation over both palmar and dorsal aspect is seen. Motor involvement leads to weakness of the little finger FDP, a positive Frohman sign, and a positive Wartenberg sign. Provocative tests include a positive Tinel at the sites of compression. Combined elbow flexion and digital compression is highly sensitive. Observe this patient's left thumb. A positive Frohman is seen when IPJ flexion is seen when the patient tries to hold a piece of paper while the examiner attempts to pull it away. Wartenberg sign is inability to adduct the little finger. This patient has bilateral cubital tunnel syndrome on the left side. Observe thumb IPJ flexion. The middle finger is overlapping less compared to the right hand. And notice here weakness of the little finger abducted. Tinel sign can be positive. This is a very useful examination technique to localize sites of compression. All patients with neuropathy should be well educated. Spending 1 to 2 minutes to educate your patient can bring tremendous results. They should be taught to avoid aggravating positions and activities while changing their daily posture to avoid aggravation. Static night sprinting helps with night symptoms. Specific stretching and nerve gliding exercise must be incorporated. There are various techniques described for surgical management. The ideal technique should address the mechanism of cubital tunnel syndrome. The strategies include simple decompression, where proximal and distal facial structures superficial to the nerve is released. Medial epicondylectomy, after releasing the facial structures, part of the medial epicondyle is osteotomized. This allows anterior translation of the nerve, reducing neural strain during flexion. Transposition eliminates both compression forces and reduces neural strain. There are several techniques described: subcutaneous, intramuscular, and submuscular. Guyon canal compression occurs at the level of the wrist. The Guyon canal is closely related to the carpal tunnel, as shown here by the red and yellow arrows. The ulnar nerve in the Guyon canal is closely related to the hook of Hammett. Causes of compression can be due to trauma, fracture non-union, anomalous muscles, or space-occupying lesions such as a ganglion cyst. The nerve can be compressed at different regions as the deficits depend on the location of compression. In Guyon canal compression, motor weakness only involves the hand intrinsics, and sensory loss excludes the dorsum of the hand. Clinical examination is mainstay of diagnosis. Electrodiagnostic studies may be useful. Again, here ultrasound can be considered together with the MRI. Ulnar clawing is more severe compared to cubital tunnel syndrome. This is due to unopposed pull of a functioning FDP. Froment and Wartenberg is also positive, and the sensation over the ulnar dorsum of the hand is intact. Conservative treatment includes splinting of the wrist in neutral position together with stretching and nerve gliding exercises. The photo here shows a friend of mine who developed Guyon canal compression after prolonged road cycling. Her symptoms improved with just abstaining from cycling for a month. Many times, carpal tunnel release surgery is enough to improve symptoms of Guyon canal compression. However, when symptoms are not relieved, formal decompression of the canal is required. Understanding the different symptoms and signs of the different levels of compression is important to arrive to the correct diagnosis. The correct diagnosis, in turn, leads to the correct management.